Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. In previous video, we discussed about thyroid gland, and its some section is remaining. So let's resume our topic. As you know that Graves' disease and thyroid storm is one of the examples of hyperthyroidism. So let's see how we can tackle them in our prescription. So as long as the Graves' disease is concerned, it's in this thyroxine production will increase, so relevant to its body abnormality will also increase. So let's see how Graves disease affect our body. It shows almost 8 signs and symptoms. Number one is enlargement of thyroid gland. Number two is the exophthalmos. It's an protrusion of eye anterior out of orbit. You just go and write exophthalmos at browser, then you will get pictures and videos relevant to that. You will easily get it. How do exophthalmos look like? So it's exophthalmos is also one of its sign and symptom, and acceleration of pulse rate and sweating and nervousness and you can say psychiatric disturbances, as well as so that increase the metabolic rate and emaciation. These are the signs and symptoms when a person is affected by Graves' disease. So let's see how to manage this. How to manage this from the implication of pharmacological therapies. So again, the same thing is that as we discussed in previous video, that we will use specifically two, you can say exclusively two drugs. That is the methimazole and PTU, propyl thiouracil. As long as methimazole is concerned, its initial dose is we will start from 20 mg to 40 mg in the morning, once daily dose. It will start initially and for 4 to 8 weeks, and then we will maintain patient at this therapy from 5 mg to 15 mg OD. And if system situation remain controls, then okay. Otherwise, we will shift it towards alternative therapy, that is the PTU, that is also known as propyl thiouracil. As I told you in previous video, that we usually prefer to use PTUs, propyl thiouracils, as compared to methimazole. Although it's effective, but we prefer to use this. So as long as this propyl thiouracil is concerned, its starting dose is from 100 to 150 mg for 6 to 8 hours, and until our thyroid level reaches normal range, which is also known as euthyroid. And then we will resume its maintenance dose. It is also between from 50 to 150 mg, but it is not for 6 to 7 hours as compared to initial dose, but it is only recommended 50 to 150 mg once daily doses. So these are two drugs which we use, which holds the major part of prescription for the management of patient with Graves' disease. So this was one of the example of hyperthyroidism. So let's move on next example, that is the thyroid storm. As you know, as name indicates, that storm, that it's an immediate expulsion or a higher, you can say excessive amount of thyroid hormone release in the blood. So it's as you know, that when thyroxine level abnormally increase in our blood, then it will also affect our system. As in normal Graves' disease, we read about 7 to 8 signs and symptoms. That symptom will affect very aggressively. Specifically, it affects on our cardiovascular system. So vigorous management is required or you can say we apply vigorous management approach to tackle this thyroid storm. Let's see how we can manage it. So we will first of all use beta blockers, that is the propranolol. And propranolol will be used between the dose of 60 mg to 80 mg every 4 hours. And it can also be implicated from, in this case, according to situation, in IV route from, you can say, and its dose is 1 to 2 mg slowly every 5 to 10 minutes. Total for 10 minutes, like we will give 1 to 2 mg slow in IV infusion for 5 to 10 minutes, and total time of this infusion would be 10 minutes. And next is the esmolol. Its dose ranges from 50 mg to 100 mg per kg, 50 mg to 100 mg per kg to control the cardiovascular manifestation. But if there is a case that beta blocker is contraindicated due to any condition or our respiratory related issues, then we will shift patient towards an alternative. We will use specifically diltiazem. that is the 90, and its dose that will be used is between 90 mg to 120 mg TDS, or 4 times per day, or you can say it can also be applicated through IV route. That is that's, you can say, its ratio is from 5 to 10 mg per hour. So the beta blocker will be used, or if it is contraindicated, then we will shift our patient towards the diltiazem. And as I have told you, this is the first management approach for thyroid storm, or you can say one of our first choice for the aggressive management of this thyroid storm. Second option is again same PTU, that is the propyl thiouracil, but here in this situation dose will vary as compared to Graves' disease, because in Graves' disease we kept our patient maximum dose was 150 mg between 6 to 7 hours. But in this situation, our loading dose fall between of our propyl thiouracil would fall between 500 to 1000 mg, followed by 250 mg dose every 4 hours. So such a high level of dose will be required to manage the situation, to control our body. But if due to any case, if propyl thiouracil is contraindicated, then we will implicate its rectal preparation. And if patient can't tolerate by mouth, then we will use 400 mg of this propyl thiouracil every 6 hours, and its maintenance dose is between 60 to 80 mg daily. So this is the second approach for the management of thyroid storm, that is the propyl thiouracil. And at third step will also implicate, we can also use hydrocortisone, and its dose would be between 50 mg IV every 6 hours. So look at this, how effective we are using beta blockers as well as propyl thiouracil as well as hydrocortisone for the management of this thyroid storm, because this is a very serious situation. Because the level of thyroxine abruptly raises in blood, it would put our body into imbalance situation. To maintain that balance, this aggressive, or you can say, yes, exactly, aggressive approach is required. So this was all about our management strategy in case of hyperthyroidism, that we discuss about the Graves' disease as well as about the you can say thyroid storm. So let's move on our point number 3, that is the about point number 3 is about the drugs that prevent the uptake of iodine in thyroid gland. And anything which prevents the iodine uptake in thyroid gland, it actually controls the level of thyroxine. So example of that drugs include prechlorate and thiocyanate and iodine and high dose of iodine. So we use high dose of iodine, thiocyanate and prechlorate for the controlling the level of iodine uptake by thyroid gland. Point number 4 is about the dose of thyroxine. Its dose fall between 150 to 150 mcg per day, and according to patient situation, for example, if patient age is above 50 year and he has no history of cardiovascular event, then his starting dose would be from 50 mcg. And if the same patient has the history of cardiovascular disease, then his starting dose would be, his or her starting dose would be from 12.5 to 25 mcg per day for 2 weeks until a normal level of thyroid is achieved. Similarly, in this period we also observe the toxicity associated with this thyroxine drug, but generally it is said that the dose of thyroxine would fall between 50 mcg to 150 mcg. Point number 5 is about a comparison between the T3 and T4, and it is as you know that T3 is 3 times more potent. So 100 mcg dose of T4 is equivalent to the 25 mcg dose of T3 because of its potency. So this was all about an introduction and abstractive point relevant to thyroid gland, and let's move on our summary. Then we will conclude this chapter here and open our new topic. As you know that we use for the management of hypothyroidism, we use levothyroxine, that is that is also known as T4, and lenothyroxine, that is known as T3. For these two drugs are being used for management of hypothyroidism. And to counter the hyperthyroidism, we use methimazole and propyl thiouracil. And in a situation where we are going to perform our thyroidectomy and preparation for surgery, is required high dose of iodine containing solution. For example of that solution is the Lugas solution and potassium iodide. These are used in preparation for surgery for thyroidectomy. And beta blocker is also used for the management of hyperthyroidism, especially in thyroid storm. And similarly, hyperthyroidism can also be managed by the use of radioactive iodide, and its example is the I-131 RAI. So, but two things we must need to be kept in mind. That is, number one is that patient who is being given, who is going to be initiate on radioactive therapy of iodine, then his thyroxine blood thyroxine level should be normal, or that patient should be on beta blocker. Secondly, this radioactive iodide should be avoided in case of pregnancy and nursing mothers. So this was all about our thyroid hormone. So our this thyroid hormone topic ends here, and now we are going to open our next gland, that is next hormone, that is the gonadal hormone. This hormone play a very key role for our reproductive system. Through the use of testosterone, estrogen and progesterone, we manipulate our system and manage various conditions of our body. So let's give a mechanism of menstrual cycle, because we're going to use its hormonal agonist and antagonist for performing, or you can say inducer and inhibitors for performing our various clinical for to achieve our various clinical aspects relevant to patient's condition. So let's begin. Let me give you a brief summary prior to go in the detail of conceptual points. So as you know that ovary produces estrogen and progesterone, and testes produce testosterone, that is the male, and in the female it produces female it produces estrogen and progesterone. So you can say estrogen or progesterone is being produced in ovary in females. So let's see how menstrual cycle works. As you know that this is a cycle begin start at puberty, and for 30 to 40 year of period of cycle functioning. This cycle is known as menstrual cycle, and at a specific age when it stops responding to GnRH, that is the hypothalamus hormone, that is known as gonadotropin releasing hormone. It stimulates anterior pituitary, that produces its gonadal hormone, that is the follicle stimulating hormone or luteinizing hormone, which actually influence this ovary and its estrogen and progesterone production. So when after certain age, female reproductive system stopped responding to this GnRH. This is a time when a new phase of our life cycle start, that is also known as menopause. So let's give you a mechanism of menstrual cycle. As you know that GnRH, that is also known as gonadotropic releasing hormone, stimulates follicle stimulating hormone and luteinizing hormone from anterior pituitary. It stimulates follicle cells in ovary, and this cell start producing estrogen, which also when you can say first time the cycle starts, this also produce secondary sex characteristic of a female. So we are not going to discuss in that. So let's move back our topic, that is the that was that under the guidance of GnRH, FSH and LH stimulates the follicle cells in ovary. This ovary start producing estrogen, whose major function is to prepare uterus for implantation. Side by side, it gives negative feedback to our anterior pituitary, which stop producing, or you can say which inhibits the FSH. So it happens in the beginning. As time passes and gradually follicle cell develops, and the level of estrogen production increases. As this estrogen level production increases, side by side its preparation of uterus for implantation, it also stimulates again to GnRH, which again releases FSH and LH, which and this second time in release of FSH and LH, you can say it is also known as increased surge of FSH and LH. It cause ovulation. So this is step where it happens often happen at the mid of month, or you can say at the mid of cycle. At the mid of cycle, so once ovulation happens, the corpus luteum start producing progesterone and estrogen. So this will keep on until our menstrual cycle ends or pregnancy happens. Till the end date of pregnancy, this level of estrogen and progesterone remains high. And when there is no chances of implantation, then corpus luteum begin to degrade, and this cycle ends. And again after a certain period, this same thing repeated. repeats, like evolution happens and degradation happens, and our the way of initial surge of FSH and LH and later surge of FSH and LH causes ovulation, and this ovulation after certain. So we use specifically this cycle, we use estrogen and progesterone level to extend or facilitate in the pregnancy, and or to maintain our restore our normal periods, are to in using the hormonal replacement therapy for the patient who has already gone into the menopause situation, because these hormones are not only important for reproductive system, but they also affect other part of our bodies, like skeletal system. So this was all as a brief introduction of menstrual cycle and female reproductive system. So we will discuss remaining section in next video about its relevant drugs and how we use to induce this estrogen and progesterone level, and to inhibit this estrogen and progesterone level for gaining various clinical advantages. So thank you so much for listening, and if you feel that our videos are helpful for you, then please subscribe my channel and stay tuned.